Okay, I think we should start the show. Thank you, guys. Thank you, everybody from all around the world who've signed in for this uh, very, very special course. Uh, I have some really, really close friends of mine as well on this thing who I must thank. First of all, thank you, all of you guys, for making it and being here. I really have to thank a few people who've helped me promote this and bring this to the particular level where it is. I must thank ACOS for helping me promote this. I must thank you to BMC, iTube as well. I also want to thank a few people, Jim Ravasio from J&J Vision, to actually help me promote this on his personal level, and David Smadja from Israel, and Bill Tratler. They did help me a lot along with my panelists to actually promote this and get it to all of you guys. Having said that, we also wanted to tell you that I'm going to give the baton over to Deepinder, who's just been an absolutely fantastic leader, a fantastic educator, and somebody who I look up to. So, Deep, all yours. The show is yours. Let's get it going. Thank you.
Thank you so much. And good morning, everyone. Good evening, depending on where you are. These are really unprecedented times. And we have learned a few lessons during this crazy, crazy time. And I think one of them is that we realize that we have a global ophthalmic community that really is more like a family to us. So, this is a time of reflection, of pause, and it's just wonderful to have colleagues all over the world. And really, Ashvin, thank you for bringing us all together. This is a time to kind of slow down and learn new things as well. So today's kind of session is going to be on iris repair made simple. And we have a wonderful cast of characters here. And I'd like to introduce everyone with a little bit of a personal touch, because now we all are family. And so here's the agenda that we're going to review today. And I'd like to introduce our speakers to start off with. So I'm the moderator, and I am Deepinder Dhaliwal. I am a professor at the University of Pittsburgh School of Medicine, and really have had a wonderful time getting to know the Agarwal family. Ashvin comes from a legacy of really brilliant ophthalmologists. And here he is, Ashvin Agarwal, with his lovely family. And when he's not busy with his family, he's actually super busy educating all of us. So he hosts grand rounds on the second Tuesday of every month. And he's wonderful with social media. So you can ask him any questions at his Instagram handle there or on Facebook. Moving right along to Brandon Ayres. He is part of the cornea service at Wills Eye Hospital. He likes to be on the moon. You can see he was inspired there during one of the meetings. And he is always a wonderful teacher. Priya Narang is the director of the Narang Eye Care Center and Laser Center in Ahmedabad, India. And she is always an amazing speaker, and we look forward to her pearls. And then lastly, but not least, we have Nicole Fram, who's really a dynamo. She is running the advanced vision care practice in Los Angeles, California, and is a clinical instructor at Stein Eye Institute, UCLA. So take it away, Nicole.
Okay, well, thank you. I'm going to try and share my screen here.
And I'm going to stop sharing mine.
Deep, you have to share. Very important. All right, so we're going to go ahead. Deep, thank you for that nice introduction, and thank you to Ashvin for inviting me to be here today. It is amazing how we can all share our knowledge internationally, and it's just an honor to be here. So we're going to talk about iris repair, and I'm going to talk about McCannel suture fixation and iridodialysis. So the surgical management of iris defects can be overwhelming. And I think that what we want to give everybody today is a systemic approach to managing small and large iris defects, discuss these basic techniques of McCannel and iridodialysis in this lecture, and then look at some IOL fixation techniques using iris suture fixation. And I think the most important thing is having your toolbox ready. And so when you get into the OR, you want to be prepared. And you can do it with different hooks, have bond hook, a Kugelin hook, a Condon snare, intracameral miotics like Myocol and acetylcholine, Myostat. The reason why you want to make sure these patients are not dilated before you get to surgery is you want to be able to control the iris. Having your suture available is extremely important. So 10-0 polypropylene, and there's many different needles that we're going to talk about. There's the CIF4, the PC7, and the CTC6. And then having your MST instruments is key. And this dispersive viscoelastic that's almost like another instrument during your case. Now, let's get into the iris defect toolbox here. So your needles, you want to make sure that before you start using these needles, that you understand how they move in the eye. So right goes left, up goes down, and you're going to be pivoting through a paracentesis. And so you want to make it a little bit bigger so that you have some wiggle room in there. And then you can either use the CIF4 or CTC6L. When you use the CIF4 needle, when you're coming out, you want to dock it into a 27 gauge cannula, because if you come out anywhere in the cornea, it can cause a leak. Whereas with the CTC6L, which is Ethicon as well, you can come out anywhere in the cornea, but it's a little trickier, a little thinner needle, and so it's a little trickier to use. The hooks that I use are the Bond micro hook, a Kugelin hook, or a Condon snare. And then you want to have your micro scissors. So this Bond hook is just a little micro hook, and it's made by many different manufacturers. The Kugelin hook is a hook that we're very familiar with, and then the Condon snare is part of the MST series. In order to do these intraocular techniques, you're going to need to have intraocular scissors to cut the knots. So especially with the Seepser knot or doing a McCannel, which we're going to show later, you want to make sure you have intraocular scissors. So here we're going to show how to do a McCannel basic technique. We have a 3-piece IOL in the optic capture position of the iris, and we're going to go ahead through a paracentesis that's made perpendicular to your throw. We're going to pull out each side. So we have one loop there, and we have another loop coming out here. Okay, and using these simulation models, this is the Simuli by Stuart Stoll, can help you kind of get used to the maneuvers that you need to do before you actually do it on a patient. And so we have these two loops. You're going to figure out what side of the loop is connected to the iris and what side is free. And then you're going to pull one side out at a time. And as you're pulling the other side of the loop, you want to hold on to the side that you already retrieved, as I'm doing right here. And you want to hold on there because you don't want to do all this work and then pull it through. It's very disconcerting. So then we'll go ahead and do, you can do a 3-1-1 or a 2-1-1-1, and then you'll go ahead and tie this knot. Now, one of the things that you want to make sure you're not doing is tying too tightly. So when you tie too tightly and you've incarcerated a lot of iris, you're going to get an ovalized pupil. And we're going to go over how to avoid an ovalized pupil in these cases. And then you can cut actually externally. You leave about 1.5 millimeters. And then this is a key part where you sweep where the paracentesis is, because you don't want to get the knot and it incarcerated into the cornea and leave it that way. You don't want iris incarcerated into the cornea. So we have our basic technique there. And what we're going to do is go ahead and show how we're doing this in vivo. So here you want to get a mid-peripheral and small bite. John Hart has this wonderful video how you can actually use a needle at the optic-haptic junction, pull everything up, and then go ahead and do your peripheral bite. But here we're just doing it all manually. I'm using 2 micro hooks here to actually show me where the suture is, because sometimes the peripheral cornea is opacified. And so we're going to go ahead and retrieve out that loop. And you're going to see here how we're going to retrieve it just where it's free, not on the iris end. Retrieve it on both sides. And then what I like to do is I like to tie one side, and then I go ahead and tie the other side so that I'm trying to give symmetrical tension. So then what we're going to do is do a 2-1-1-1 in this case, but you can do a 3-1-1 for good luck. And then we'll go ahead and tie this, and we'll show this sweeping maneuver that we want you to do so that you can make sure that the knot's not incarcerated. So here we're cutting the knots here, and then we're going to go ahead and push the optic back. When you're pushing the optic back, you don't want to rotate because you don't want to rotate your haptics out of the position. And then we'll go ahead and sweep. Now this helps you get around to round out the pupil. We're going to grab at the pupillary margin and go ahead and with a Sinskey hook, untuck some of the iris there. Now these cases, you want to check if there's any vitreous prolapse at the end and go ahead and use preservative-free triamcinolone. Go ahead and use your miotics to bring the pupil down and then check to make sure nothing's leaking. So we're not going to dilate these patients preoperatively. We're going to use intracamerals to control everything. And then we're going to start when we're doing our suture fixation of these lenses with a McCannel, which is a little bit easier to learn than the suture. So I'm going to move forward here. So how do we avoid this oval pupil? And so what I want to show you again here in kind of slow motion is that pupil is a little bit peaked. I'm going to grab at the pupillary margin. I'm going to take the Sinskey and try and kind of untuck over incarcerated tissue. The two reasons for pupil ovalization is too much iris is incarcerated or the suture is not mid-peripheral enough. So if it doesn't look good, go ahead and make another throw and get it right so that the patient has a great cosmetic result, especially in a blue eye. So the take-home points on McCannel pearl and McCannel pearls are mid-peripheral or peripheral iris defects is what I use McCannel for. Make a paracentesis at the midpoint of the suture throw. So the red arrow shows where the midpoint of the suture throw is. Then you pull out these two little bunny ears, and then you pull the end that's free on each side to then begin tying. And we want to free that iris and the knot from the paracentesis with a spatula to avoid incarceration into the cornea. I have received patients that have the actual IOL suture to the cornea because the doctor didn't sweep the paracentesis prior to doing it. So next, I wanted to give it to Deep for a moment to see if anybody has any questions that we want to answer about McCannel.
We don't have any questions about McCannel right now, but there were some questions about recordings available afterwards. And yes, indeed, this will be posted. This entire webinar will be posted on iTube and the ISRS webinar series.
Okay, great. So next we're going to move into iris repair. Iridodialysis repair can be a very challenging technique to learn, and we're going to try and simplify that for you. So when we think about iridodialysis repair, it really, in 2011, Mike Snyder and colleagues reported on this non-appositional repair of an iridodialysis. And this is kind of known as the hangback technique of iridodialysis repair. And there's many other, like the sewing machine technique that we're going to talk about later, but I'm going to stick to the hangback technique, which I use very often. Let's go back to our toolbox. It's the same thing, but really we're just going to focus on using the CTC6 with a curved needle or the STC6 with a straight needle. And Ike Ahmed has shown at the back of the needle, you can bend it a little bit to get it across the eye a little bit better. And then docking this, you can dock this or just kind of put it right through the sclera if you're at the right angle to dock it into a 27 gauge needle or a 25 gauge needle. And once again, we're going to use our MSTs, have our Proline available, and our viscoelastic. So let's see how we can do this and mimic this on a simuli before we go ahead and do this on a patient. What we're going to do is create the iridodialysis. Typically, we're 1.5 millimeters posterior to the limbus, but really you just want to be anterior to the scleral spur, and you take the conj down, you'll be able to see that. You actually want to make a groove before you put your 26 gauge needle in, and then that's the suture coming across, and you only want to grab about 1 to 1.5 millimeters of the peripheral iris, so you want to be able to show that to yourself. So we're going to kind of pick it up and kind of show it to ourselves. And that's a little bit too much, right? So you can readjust in the eye. And as you're coming out, you really want to make sure that you're watching the needle as you're coming out, because watch what happens here to the lens that was fixated. You see how it moves? See how much that moves? So you really need to understand how you need to maneuver. And if you see the lens moving, just let go, let it sit, and then grab it from a different angle and come out. We're going to tie this in a 3-1-1 or a 2-1-1. And, you know, Proline is a little bit more difficult to use. Let's say you can't bury the knot or you can't move it. You can just leave the ends long under the conjunctiva, not too long, but long enough that they won't poke through. Here, we're able to actually bury it. Then we cut the ends, then we finish burying it. So you want to prove to yourself that you can bury it. And that's one of the good things about docking into a 25 or 26 gauge needle, is that you actually can make sure you have a hole big enough to bury it. So let's get into a case here. This is an iridodialysis repair for a patient who had a traumatic cataract. You can see that there's cataract, there's zonulopathy, and a fairly large iridodialysis there. So we basically took the lens out, we put an Ahmed segment in, we're using intracamerals, and now we're preparing to do our iridodialysis repair. Now for the novice surgeon, I would recommend that you go ahead and do this 6 weeks later when the capsule and everything is all opacified. Once you become comfortable with using this technique, you can go ahead and do this at the same time as your primary case. But really coming back later is a nice thing to do. So what we're doing is we're doing 2 mattress sutures, and we're coming across the eye. We're watching the needle as we bring it out. Then we're gonna, before we tie, we're gonna untuck that iris and then go ahead and tie. So I have 2 mattress sutures there coming out of a groove that I made 1.5 millimeters posterior to the limbus. Now, if you're gonna do a kind of modified cerclage, you wanna make sure you have your good iridodialysis repair performed. You can see this iris is very atrophic. We need to be very careful in the area where we have the Ahmed segment because we don't want to ruin our capsulotomy. So coming back later is just fine. And this is a suture technique, which Priya is going to go over later, which shows how you can actually close pupillary defects and do a modified iris cerclage by using the suture technique and the sliding knot. So in this case, what you observe is that we can have a nice iridodialysis repair and we can have a cerclage and everything finishes up nicely. Now, once again, in these cases, you want to make sure you go ahead and close your conjunctiva, use your preservative-free triamcinolone because vitreous can prolapse forward, particularly in zonulopathy cases, and make sure we're watertight at the end. So this is the pre-op photo. This is the post-op. It's not perfect, but it's definitely much better than it was prior to surgery, and the patient ended up very happy with the surgery. So the take-home points on the iridodialysis repair, we can dock into that 27 gauge needle or we can exit, but it's all ab interno, and that hangback technique is a wonderful technique to learn. Another thing to understand is that if you go 180 degrees to try and repair, you may not have enough wiggle room if you're not docking. And so try and put your paracentesis and shorten the distance to the iridodialysis repair. And then determine the location of the scleral fixation by the limbal landmark, or just anterior to the scleral spur, the blue zone. So it's approximately 1.5 millimeters posterior to limbus in both eyes, but make sure you can really see the surgical limbus. And then you can place these sutures in a groove. Like I said before, if you can't bury the knot, just leave the ends long. And then we talked about how you need to fix the iridodialysis prior to the cerclage and be very careful with the cerclage. So in summary, have your toolbox ready. Practice with simulated eye models because you need to understand these needle ergonomics. It's very tricky in the eye, and if you have practice, then you'll have a lot more confidence. And then understanding where to put those paracentesis so you have the shortest distance will give you great success. So thank you so much.
Fantastic. Thank you so much, Nicole. That was wonderful introduction. We appreciate all your comments. And as we're switching over to Priya Narang's slides, I'd like to do a bit of a housekeeping.
Yeah.
One is that there's 2 buttons that we want you to keep in mind today. One is the question answer. We will have time for question and answer at the end of everyone's presentation. So please go ahead and type your questions in now, but we are going to address them after all the speakers have had a chance to do their presentations. The second thing is if you're having any bandwidth issue or connection issue, please put that in the chat box. So question and answers in the question and answer box, and any other issues can go into the chat button. And so then our AV folks can help you there. Okay, wonderful. Let's switch gears. Priya, please show us some great cases.
Thank you. Yeah. Is that visible
No, it's not shared yet.
Not as yet.
now?
Not yet.
Oh,
So Nicole, did you stop? You stopped sharing your screen, right?
Yeah, I did.
okay. Okay. I think it should come now.
Yes.
Yes?
Yes.
Yes.
Wonderful.
Can you? Yeah, that's it.
Yep. Yep.
Yes.
Sorry. But yeah. Is that fine?
Perfect.
Perfect.
Okay. So a big hello to everyone, and I move on to my topic. I would be addressing three major topics. So this is the first one, the modified Seiff's slipknot technique. So Steven Seiff, he described the slipknot technique, and after that, Osher et al., they came up with the modified Seiff's slipknot technique, the basic difference being the method in which the knots were taken and it created a locking knot. So the basic thing that you require for this surgery is you can do it either with a 9 or with a 10 polypropylene suture on a long needle, which can be either straight or curved. It depends upon the surgeon's preference. I prefer to use a straight needle. The second thing that you need in this procedure to do is, as Nicole had said, you need hooks, the micro hooks, you need a micro scissors, and you also need the tying forceps. So I will show you this case. This is a case where you're now seeing that there is a superior iris defect. I mean, this was a complicated case, and this was the last stage where pupil reconstruction had to be done for the case. So I have deliberately slowed down this video for everybody to appreciate. So what actually it's now going is that I have taken the 10 needle and I have passed it from, I just paused this here, I have passed it from the corneal paracentesis. It is engaging the proximal iris tissue, engaging the distal iris tissue, which needs to be approximated. And I have introduced a 26 gauge needle from the other paracentesis incision now. And the next step that I'm going to do is I'm going to thread the tip of the suture needle into the barrel of this needle, and that creates a railroad method, and it helps to pull this needle out. You might not even do the railroad. You can even do without using this needle, but then this helps you to secure and you actually know where your needle is actually passing through. So once you have pulled off your needle, now the next thing that you do is you just take, I just pause it again. You take a micro hook, you pull the suture out from the corneal paracentesis. So now what you actually have is you have a loop, which you are seeing here, and you have a suture end. Now you take up this suture end and you pass through this loop at least twice, maybe thrice in the same direction. And then you pull both the suture ends, the left and the right. And then what happens is this knot, it just slips inside through the paracentesis and it approximates the iris tissue. So this is the first step which is done. And then you again repeat the same thing. You pull the loop and again you do the procedure. You can do 2-1-1 or a 3-1-1, whatever. And it creates a locking knot. And then you take a micro scissors and you cut the suture end from there. So this is basically how this procedure is done. This is another surgical video which I'm trying to show you. Again, as you see in this video, you again have to approximate these two iris tissues. So again, you take up the 10 needle and it is passed to the corneal paracentesis. One point that I would like to emphasize here is that whenever you pass it from the corneal paracentesis, be very careful that you do not engage any corneal tissue, because the first step, if not done properly, can lead to the failure of the entire procedure, because the suture does not slip inside. It gets entangled into that corneal tissue. And the more you try to pull and try to approximate at this stage, you know, it can tear your peripheral iris and you can get a iridodialysis also. And you actually need, you are then in a mess and then you need to redo the procedure. So you have to be very careful of not impinging any corneal tissue when you do the surgical procedure, be it any pupilloplasty procedure. So this was it. So I go on to my next topic, which is the riveting double flange technique. So this technique, actually, we use it for an iridodialysis repair. Yeah. So I was at the double flange technique. So the basic requirements for the technique are the 6-protein suture, which we cut down into small pieces of 5 to 6 centimeters. You need a low temperature cautery to create a flange that you are seeing in the top picture. And you need a 30 gauge needle. And you also need a needle holder, which compresses the flange, which you're seeing in the lower picture. This just widens up the flange, and therefore it has a greater area to imbibe the iris tissue and hold on to it. So basically, this technique was described by Dr. Mami Kusaka and Dr. Akimoto from Japan. And what you see here is a traumatic iridodialysis, which is sectoral. In this, what we have done is a limited conjunctival peritomy is done, and you make a scleral groove. Initially, you would just go ahead and do the cataract procedure that we do as usual. But coming up to this technique, what I would like to say is that in this technique, the 6-protein suture, the advantage is it is widely available. And when you cut it down into pieces, as you're seeing here, you can just cut down and remove the needle from the suture. So now you have an entire long suture at your disposal. And then you make small, about 5 to 6 centimeter pieces. You take you have to create a flange. So you take a low temp cautery. You do not have to touch the end of the suture. You have to get the low temp cautery a little bit away from that, because you do not really want to burn the suture. You have to have a slight melting of the suture, in the sense that it just creates a flange, and it is just enough for that. So now what you do is you have taken a 30 gauge needle. The 30 gauge needle is introduced from this scleral groove that is created. It goes inside and it engages the peripheral iridodialysis area. And you then take up the suture where you had created the flange. And now you just thread it into this 30 gauge needle. So once you have a sufficient amount of suture that has entered inside the needle, you just pull the needle. So this needle actually pulls the entire suture along with it, that piece along with it. And now what you see is that flange which is going into position, and that flange on the inner side is going to hold the suture into its place. So now you take up another piece and you again create a flange. Now how many pieces you actually need, it depends upon the amount of iridodialysis that you actually want to correct. The second important thing when you are doing an iridodialysis repair is, you need to be very sure of the amount of the iris tissue that you're actually imbibing into that 30 gauge needle, because that is very essential. Because if you tend to employ almost all of the iris tissue, when you will retract it, your iris will look quite a bit retracted on the side where you have connected. So you really do not want that. So you have to be very judicious enough to understand that how much you actually need to do that. So now what you see here is the second flange has also come into the position. So now on the other side, on the scleral side, you cut down the extra amount of suture which is there, and then again you create a flange. So this is now a double flange. You have two flanges which are supporting the iris tissue into its place, the inner one and the outer one. And this is how this technique actually works. So then you just you can just bury these knobs, the suture knobs, into the scleral tunnel which you had created. It's a partial thickness kind of thing. And then you can just cover up this area of conjunctival peritomy with either of it in glue, or you can use, some surgeons, they use cauterization on either side to retract the iris tissue. So this is the pre-op and the post-op image of the case, and this is how it actually looks like. So we go on to the next. This is just a small thing which I'm trying to mention, that we have just come up with this thing, is the trocar assisted hang-back technique. So so what we actually do in this is, we use a trocar, which is it's a 25 gauge trocar, and we pass the suture needle through that to engage the iris tissue. Now, actually, this is just a modification of the original technique. It's just that you are just using it to prevent the imbibement of the corneal tissue, which is very important. Because what actually happens is that if your corneal tissue gets imbibed into this, those the loop of the double arm suture does not go into position. It remains here. So you need to do that. So this is just a very simple thing, which I had also done this technique in a way that I had used the iris depositor and I just used the iris depositor to just compress the paracentesis and just pass the needle right in very close proximity to the metallic level of the of the instrument. So what actually happens is that, the chances of imbibing of the corneal tissue is almost not there. I think almost all the surgeons who are doing pupilloplasty procedure, they have come across imbibement of the corneal tissue somewhere down the line. So this is how probably you can just prevent it. So I just thought, let me mention to this. So going ahead with the pinhole pupilloplasty. Now, this was my third topic, which I'm trying to focus onto this. And I have just mentioned some of the related peer-reviewed papers that have been published, because in case anybody wants to go through them for detailed analysis, they can go through that. So basically, the principle for the pinhole pupilloplasty is that, it blocks the distorted rays emanating from the corneal periphery, because this procedure, we usually do it in cases with corneal higher order aberrations, where patients have very high astigmatism and irregular astigmatism. So this basically, the central pinhole, it allows the central or the paracentral rays to enter inside the eye. And we all know the importance of pinhole visual acuity because it's the final measurement of the amount of and the type of the visual acuity that the patient is going to achieve in the postoperative period. So going ahead with the principle of the pinhole optics, for this, for doing the pinhole pupilloplasty, a person also needs to understand that how the procedure is done, because you need to understand what is the reference marker that is taken up during the surgical procedure. And I would like to say that it's the Purkinje image that is being taken up as the clinical reference marker for doing a pinhole pupilloplasty. Now, we all know that we have 4 Purkinje images, but characteristically, 2 is almost non-existent. So it's always 1, 3, and 4, which is important. But out of all these, P1 reflex is the main reflex, which you see, which has been marked with a yellow arrow. So the centration of the entire pupil intraoperatively is done along the P1 reflex. Now here, the P1 reflex, it actually depends upon the type of the microscope that you are using. You might get a different type. Here, what you are seeing is a triangle, a small, a big illumination on the top and 2 small lights on the bottom. If you have a different kind of microscope, you might probably get just 1 reflex or 2 reflex. So you actually need to analyze where is the Purkinje image 1 reflex, and you need to center your pupilloplasty procedure along that. So this, what I'm trying to show you is that before I show you the surgical video, what I'm trying to show you here is that, you see the top row, it's A1, that's the preoperative image. B1 is the intraoperative image. This is after the surgical procedure has been done on the patient. You can see that Purkinje image reflects right into the center of the pupil. And then the C1 that you are seeing is the postoperative image of this of that case, which is taken on a slit lamp. Similarly, the below row that you are seeing, A2, B2, C2. A2 is the preoperative, B2 is the intraoperative, where again the emphasis is on the centration of the entire procedure on the Purkinje image, and C2 is the postoperative image. It's the postoperative slit lamp image, probably taken on post-op period, later during the postoperative period. Another emphasis, what I'm trying to say now is that the emphasis on why pinhole pupilloplasty works is that there's a decrease in the cord mu level that is seen in these cases. And actually, I would just brief up in one line. We all take angle kappa as the measurement angle, which is the angular distance between the pupillary axis and the visual axis. You are seeing here PA is the pupillary axis and VA is the visual axis. What happens in the post-operative period that you see on the right side is the pupillary and the visual axis, they come together. So for the detailed analysis of this, you can go through this paper, which I have just mentioned below that. You can just take a note of it, and probably this will help you to understand how this procedure actually works. This is the pentagram image as it is seen. A is the pre-op, B is the post-op, where you actually see that the cord levels are going down. And what you see here is there is a closeness of the pupillary and the visual axis. It comes together in the postoperative period. So for this now, I'll just show you the surgical video for this. This is a case of a radial keratotomy. You are seeing so many cuts are out there. This patient does not have a very wide pupil here in itself, but still the patient has lots of aberration, and the visual quality and vision is quite down. So we decided to do a pinhole pupilloplasty procedure for this case. And what we try to achieve in this procedure is that we try to have a pupil of about 1.5 millimeters in size. So that's usually the target. of doing a pinhole pupilloplasty. The surgical procedure that we adopt while doing this is a single pass 4-through pupilloplasty procedure. I'm not going to emphasize on this procedure because Ashwin is going to cover up that. So this actually you need multiple passes when you are doing a pinhole pupilloplasty. Probably you might need a 3 or 4 attempts. So when you try to do this, you need a surgical procedure that has minimal interventions into the anterior chamber. So that's the reason that we use this, but otherwise you can do it with any other surgical technique of your choice. So now what you see here in the postoperative period is the centration of the pupil on the Purkinje image. So this is how this actually works, and it helps you to achieve the pinhole size of the pupil in the postoperative period. So the suggested reading for this would be, I'm just mentioning these 3-4 papers, which are very essential to understand the entire principle and all. And I hope, because I cannot explain everything here in the webinar, so you can just take a note of this if you wish to. And if you have any questions, please do email me at my email ID. So thank you for your attention. So I would like to end my presentation here.
Thank you very much, Priya. That was fabulous, really interesting techniques. And I know there have been a few questions. So 1.5 millimeters is what you're aiming for. What are the issues with diabetic patients, you know, dilating them after surgery?
Yeah, I just stopped. Yeah. Sorry, yeah, Deep, please.
Any issues when you have a 1.5 millimeter pupil with dilation and evaluation of the fundus?
We have done a study on this also with this in these patients where a little amount of dilatation is seen in the after putting the dilating drops, and it is enough to allow you the examination of the posterior segment. But in case if the surgeon there is some intervention that is to be done, then I think probably the surgeon might have to remove those sutures, and they just come off easily because what you need to do is just pass a hook beneath it and you just pull it off. So if any intraoperative maneuver is to be done, they can be easily removed, or maybe you can even ablate it with a laser if you want it. But otherwise, yes, it does allow the posterior segment examination. It's sufficient for a posterior segment surgeon to see. Yeah.
Thank you. Thank you. Okay. You know, this has been a great lesson in AV for all of us. We've had to become Zoom savvy. So let's go ahead and move on to Brandon. Thank you.
Okay, just to confirm, you guys are seeing my screen?
Yes, sir.
All right, so I have taken the ultimate in social distancing, and I am doing my presentation from the space station Mir. Coronavirus is not getting me. And luckily, they've got coffee in the space station, and it's pretty good. So my charge is to talk about the Ayres cerclage technique as well as Ayres prosthesis, some pearls and pitfalls. And I will say that most of the key videos in my presentation are also either already on YouTube or will be on YouTube shortly. So I know video transfer with some of these can be a little bit challenging. So if you're not able to see what you want to see, check YouTube either today or within a day or two, and it should be there. And I wanted to start with the Ayres cerclage technique. And like Nicole had mentioned, you're going to need some tools for this. But the technique is actually fairly easy to understand. Certainly this is going to be easier. Actually, I would only do a cerclage, a true cerclage, if somebody is pseudophakic or becoming pseudophakic that day. And there are many, many different types and techniques for the procedure. I'll show you how I do things, but there are other ways to skin the cat. Most important thing is not to get any fibrils of the suture stuck in the cornea. Now, typically, this is going to take about 4 paracenteses, and you're going to carefully pass a suture through the pupil border using a baseball style stitch. So this is a spiraling suture, not a in and out suture. And then you're going to pass this suture through the cornea from paracentesis to paracentesis 4 times. Each pass, you're going to try and grab the pupil border 4 times. So in the end of this cerclage, you'll have about 16 bites on the iris border, and that's going to give you a nice round pupil. Some of the tools you're going to need, I actually like using the CIF4 10-0 polypropylene suture. You're going to need some kind of a micro grasper. Whether you're using disposable retina instruments, I use the the microforceps made by microsurgical technology, but you need something to hold that suture, and you're probably going to want to use a micro scissor to cut the suture inside the eye. So this video, I'm sure it's going to be a little bit choppy, but just try and take a look. So we're using that curved 10-0 polypropylene suture. Notice that the cataract is already done. I would second Nicole's comments that if you are a little unsure of the technique, it is fine to stage this, doing the cataract first, coming back a few weeks later, and then doing the cerclage, because you do not want to wreck that very challenging cataract surgery that you probably just completed by passing this needle into the eye. And it can be very, very frustrating to control this needle inside the eye because there's actually two fulcrums. One of them is where you're holding the needle with a needle holder, and the other is the paracentesis. So when you want to go up, you have to push down. Left is right, right is left, and it can take your brain a little while to figure this out. Notice again, we're going to use a cannula to help this needle exit the paracentesis. In this case, I'm just using the cannula on the OVD. And that's going to help us exit the eye. We'll go back in through the same paracentesis we just exited, go across the eye. Now, very often I am changing the hand that I'm holding the needle holder with. So we're going to suture with both our right hand and our left hand here. So it's a little bit of a lesson in patience sometimes. Here we are going up, and then we'll finally go across. Remember, in each one of those passes, I'm trying to grab that pupil border 4 times to give us a total of a 16-bite cerclage suture. Now we're going to tie what's called a McCannel knot. This is a modification of an intraocular knot. It's a McCannel suture that we've then pulled into the eye. And this video doesn't do really great justice showing that knot, so I have a video dedicated just to tying the knot. So here in this case, we are going to just be finishing with the cerclage suture. So all of our sutures are passed, and we've got our entry and exit suture coming out through the same paracentesis. And we're going to start on the surface tying a 3-1-1. So we're going to pass our first row of 3. We'll add a little bit of tension onto the knot, and you'll see the pupil begin to come down. And then we're going to let that knot drop into the eye. And I'm going to pause my video in just a second. And now I'm going to grab one end of the suture inside the eye, one end of the suture outside the eye. And that's going to allow me to constrict the pupil to the size I want. Now I'm going to try and do something that may or may not work. I'm going to try and use a telestrator to show you guys where this suture is. And I can't actually see what I'm doing, so here is the Prolene suture going around the pupil border. And there's a row of 3 right here. Now one end of this suture is coming out this way, and I'm grabbing onto it with my needle holder, with my tying forceps. The other end of the suture is going through my microforceps and then up and back out. So we are pulling on the suture here, and we are pulling on the suture here. And by doing that, we can add tension on our suture and carefully adjust without pulling the knot out of the paracentesis like you would do with a typical McCannel suture. So it's really a fairly simple technique to understand as long as you've got instruments that can hold a suture inside the eye. So it's really, I think, helpful to have a good set of anterior segment instrumentation. And there you can see the pupil constrict. We'll then add another 2 throws to that suture, so it ends up being a 3-1-1. Each time, we're going to start the suture outside the eye, let the knot drop into the eye, and then finish the suture inside, tightening it inside the eye. Then at the conclusion of your 3-1-1, we'll use an intraocular scissor. Again, that way we don't have to pull that whole cerclage suture to the paracentesis, and we'll cut that knot inside the eye. And I typically will aim for a pupil size of about 3.5 to 4 millimeters at the conclusion of the case. That seems to be the pupil size that still allows retina to see inside the eye or allow us to see inside the eye, but still give a good visual outcome and reduce the glare that the patients often complain of when they have these large pupils. Now, some common difficulties. What if you can't, just ergonomically, you can't get from one paracentesis to another? Well, that is not that big of a deal. what you can do is just use a different paracentesis. In this case, I'm going to end up using the main incision from the cataract portion, or actually in this case, it was an IOL exchange portion of the surgery. And then you can simply back the suture out and through the paracentesis you were initially intending to use. So in this case, the suture, I brought it out through the main wound, and then we're going to back it back through the paracentesis. That way we can continue with our cerclage suture up and around. All right, so don't worry if you don't initially find the paracentesis you were looking for. What if you have to do something later on? Well, here I did an IOL exchange and a cerclage suture, and lo and behold, post-op day 1, the implant I exchanged was dislocated. Well, not the end of the world. You know, you cry a little bit, but you can cut that suture and the pupil will dilate once again. Now, here we're going to do a combination of an Ayres fixated IOL, and at the end, we're going to replace the cerclage suture. So if you need to get back into that eye, you can take that cerclage suture out and you're right back to where you were before. And here's a short video of where I did actually capture my suture in a paracentesis. So instead of getting a nice round pupil, I ended up with a triangular pupil. But all you have to do is free up the suture from where you've incarcerated it in the cornea. You tie it back together, let it drop into the eye, and then you can complete your cerclage. So in this case, it's a cerclage suture, and there are 2 knots instead of 1. So even if you do get the suture stuck in a fibril of the cornea, it's not the end of the world. You don't have to start from the very beginning. So quick review. 1, make sure the iris is pliable enough to make a cerclage suture. And I always tell patients, I'm going to try to do a cerclage, but if there's just not enough pliability to that iris, and sometimes they get very cheeseclothy, very friable, it won't constrict and we can't do it. Make sure you're exiting those wounds with a cannula to make sure you don't incarcerate any fibers from the cornea. Carefully tie that knot outside the eye, then drop it into the eye using the McCannel knot and adjust using microforceps to the correct pupil size, and then adjust the tension and then cut that suture with an intraocular scissor and your cerclage is done. It sounds so easy. Now, there are cases where we are not able to repair the iris. The damage is too great. There's been too much iris removed, or maybe the patient was born without an iris and you can't do repair when there's no iris there. Well, at least here in the States, we now have the Human Optics Artificial Iris, and Nicole was an investigator with me in this FDA study. We've now had approval for about a year. So Nicole, if you see anything, feel free to shout. But this is a silicone iris prosthesis. It's the custom flex iris prosthesis. Each iris is custom made for that patient. Wow. So they don't necessarily come off a shelf. They make the iris when you send them a picture and a request for the prosthesis. It takes about 2 months to get the prosthesis made, and it's available with a with fiber, which has a impregnated meshwork into the silicone fibers, or a without fiber version, which is much more pliable, which is the one that you can see in the background that I'm sort of squeezing and stretching around. Now, unfortunately, you have to pick what prosthesis you want to use before actually doing that surgery. And I'm sure many patients or many doctors will tell you that sometimes you go into these surgeries with one plan and you come out with another. So you have to be somewhat flexible as to how you're going to manage these surgically in event you end up with capsular compromise and you want to do an in-the-bag fixation and now you can't. So you got to be very comfortable with your suture techniques, not only with IOLs, but also with the synthetic iris. So the without fiber prosthesis can be used for in-the-bag fixation, sulcus fixation, or suture fixation, meaning you can suture the iris prosthesis to the scleral wall, but you can't suture really anything to the prosthesis itself. It just doesn't have enough structure to hold things in place. The with fiber prosthesis can go in the bag, in the sulcus. You can suture fixate it, and you can suture an IOL to the back of the iris prosthesis itself. I'm not going to show every technique. We just don't have enough time in this webinar. But I think the more common techniques that are going to be used are the in-the-bag fixation or sulcus fixation. So let's look at in-the-bag fixation. You're going to have an intact capsular bag, okay, including the capsulotomy and capsulorhexis, okay? You can't put one of these in the bag if you don't have an intact capsular bag. If this is a primary surgery, strong recommendation is to put a capsular tension ring in at the time of surgery, and make sure, and this seems pretty simple, but sometimes you forget in the heat of the moment there, place your IOL and the CTR before you place the prosthesis. It is very difficult to shoot an IOL through that 3.5 millimeter artificial pupil. Now, the case that we're watching here is a patient who had a cosmetic iris placed in Panama several years ago, ended up with UGG syndrome, glaucoma. He now has a tube shunt, and he's got a very atrophic iris. And this is a bilateral process for him. So I'm only showing one eye, but he ended up having both eyes done. The cataract is already out, and you can see that we put a capsular tension ring in. Capsular tension ring in. I'm removing the majority of his iris so that his atrophic iris doesn't cover up the color of the prosthesis. This is a now tree-fine to size silicone iris prosthesis. These are really squirmy. It's not so easy to get these into the inserter. And this is the Silver Series inserter made by AMO. This is the inserter that we are using for the prosthesis. It is not necessarily made for the prosthesis. We've adapted that inserter to work. And you can see that we've also stained the capsular excess, the capsule again with Vision Blue. And that is for this step here where we are tucking and pulling and trying to get this iris prosthesis into the capsular bag. And having that counter-stained capsular bag is really helpful so we can see exactly when that iris is finally completely in that capsular bag. Now, at the end of this case, at the request of the patient, I was able to use a vitrector and pretty much remove the majority of his natural iris. That way, the color of the prosthesis would shine through and it wouldn't be clouded. I do not typically vitrect away the iris, but if you need to, you can. And I do think that especially in an in-the-bag fixation, in a patient who's a myope and you've got some space between the capsular bag and the iris, you can actually, the natural iris can cast a shadow on the prosthesis and it makes it more obvious that it's a prosthesis. So more and more now, I'm removing a little bit of the natural iris if the defect was large enough. But there's an in-the-bag prosthesis. Make sure you have an intact rexus. CTR goes in, then the IOL. Measure the capsular bag. There's a little intraocular ruler that I used. That is the Snyder ruler. It's made by Microsurgical Technology. Then I take about 1 millimeter off the size that I think the capsular bag is. Tree fine, using just a handheld tree fine that iris down to size, and then carefully insert it into the capsular bag. Just a couple of examples of patients who have had a in-the-bag prosthesis before and after pictures. This is a patient of mine who was aniridic. He chose his brother's iris color, and we did bilateral surgery on him. Really remarkable surgeries and very fun to do. Now, passive placement in the sulcus is another common and relatively straightforward way to get a prosthesis in. And many people think that placing it in the sulcus is probably the best spot for it. That way we're not worried about phimosis of the capsular bag or the capsule changing the apparent color of the prosthesis. In fact, I think Kevin Miller, Nicole, right? I think he prefers sulcus placement strongly. Well, in this case, there's really not a need for an intact rexus, assuming that the anterior segment is relatively stable, especially for passive fixation. But if you need to, you can suture fixate a with or without fiber prosthesis into the sulcus if there's just not enough support from the overlying iris to hold this in place. And I actually made a mistake in a patient of mine where I only put in one suture to hold the artificial iris in place in the sulcus, and I really should have placed two. I ended up returning that patient to the OR several months later to put a second suture in. So I would always balance the sutures, one top, one bottom, or side to side. So here's a straightforward case of patient with floppy iris syndrome who had a multifocal lens placed. And you can see right over that temporal wound where there was an excessive amount of iris prolapse during the surgery. He just lost about 1/3 or even more of the iris and was really symptomatic with glare and very unhappy. He was kind of an unhappy guy to begin with, but the iris defect made him even more unhappy. But here, that IOL is in good position. The capsule is completely intact, and he's got a fair amount of iris to act like a spring clip to hold the prosthesis in place. So this is a without fiber prosthesis that is not tree-fined at all. This is the full size, 12.8 millimeters, and I'm just putting that right into the sulcus. Very straightforward placement. Although the video is not 3D, when these irises unfold in the eye, they are sizable. So I would be use a lot of OVD to protect that overlying cornea and endothelium. And there you can actually see, and one of my concerns was, would the artificial iris do a good job centering over the center of the multifocal IOL? And you can see in this video, the centration of the IOL and the artificial pupil is really quite good. And he's done very nicely. So here, we already have an IOL in the eye. We have plenty of overlying iris to hold the prosthesis in the sulcus. And I used a fiber-free design, and I did not have to fixate it. And here are his before and after pictures. And you can actually get a little sense as to that shadowing effect that you can get, right here along that artificial iris border. But in his case, it was really minimally noticeable, and he was quite happy. So when it comes to the artificial iris, you have to make that very careful surgical plan, and you have to know what you're going to do 2 months before you actually do it, because you have to take a picture of the patient's unaffected eye and send it to human optics to make the artificial iris. Make sure you're going to place a CTR and the IOL in the bag before iris prosthesis placement, especially if you're going to do an in the bag placement. Tuck that prosthesis very carefully into the capsular bag or sulcus with lots of OVD, and have your backup plan ready. You never know what's going to happen in these traumatic cases or aniridic cases or whatever the case may be. You've got to have your plan A, B, and C ready, and be ready to suture if necessary. Thank you very much. Coming from you from space, Brandon Ayres. Any questions?
That was fantastic, Brandon. Thank you so much.
And again, the majority of these videos are also already on YouTube. So if you didn't get what you want from the presentation, just go to YouTube. And shamelessly, I'll hit the, click the subscribe button. I need some more subscribers.
Okay. So that was fantastic. So videos are available on YouTube for Brandon Ayres. This entire webinar will be on iTube and also on Ashvin Agarwal's Facebook page, correct? And on the ISRS multimedia library. So these will be completely accessible to everyone. And one thing I want to mention is that during this pandemic time, ISRS has opened up the multimedia library to everybody. So you don't need to be a member, you don't need a special password, you just can get in there. So it should be wonderful. So we're going to now go back to Priya because her videos are working at this point. She's woken them up, and then we'll finish up with Ashvin. Okay. And please, we will, I promise, have time for questions. I just heard from Dr. Agarwal that we can go an extra half an hour so that we will have time to answer all the questions after everyone has had a chance to present. So please keep those questions coming in. And for the panelists here, I'd like you to go ahead and review the questions and then pick your top 2 or 3 to address first. So let's go back. Okay, and now for our final speaker of this morning, it will be Ashvin Agarwal. And I see he's already had his screen sharing with everybody. So take it away, Ashvin.
I hope everybody can see my screen and hear me loudly.
Yes.
Okay, perfect. Let's go. Share again. Is it live now?
Now it's live. Thank you.
Let's just, I'll take it again. No worries. Is it playing? Because
yes. Yes.
Okay.
Now it's playing. Thank you.
Okay. So let's just break this down. What we have here is a split end of a coloboma case, but let's try and understand how this works. Is a proximal iris and a distal iris. Now you make a stab wound at the distal side. So you always make the stab wound on the distal entry, not the proximal, because the proximal takes only the ninoproline suture. Ninoproline goes through the proximal incision, goes through the proximal iris. I hope everybody is seeing this clearly. 26 gauge needle goes through the distal iris via the distal incision. Now railroad that technique all the way, railroad this all the way out from the proximal to the distal. Now break down this suture, because this is one of the biggest questions that I'm asked all the time. Where do I pull the loop? So understanding the suture trail. Now there is a suture trail, part 1 to part 5. There's 1 is external to proximal incision. Then you have proximal incision to proximal iris to distal iris to distal incision, and distal incision to external. That's part 1 to part 5, as I have explained it in this video. Take through the distal incision, take the loop from part 2, bring it out. Now, once this loop, put it on the conjunctiva, cut part 5 and throw this 4 times through into that loop. I'm going to put this up on my Insta and my Facebook pages. But what this basically does now, all you have to do is pull part 1 and part 5 apart. All you'll get is both those ends coming together in a helical knot, which is what is being formed. And that's it. That's the end of the procedure. I don't think we need to, I don't think it's necessary to go ahead and do one more. At least we've had a number of years of follow-up of this now, and not had this loosen out or give way. I think that was one more question that was asked during my topic here. So where do you use these? Where do you use this? Any pupilloplasty, in fact, you can be using this. And the applications have just exponentially involved. Pupil defect, uridzavalia, appositional angle closure, high astigmatism, pseudophakic bullous. Let's understand one of them. I'm just going to take one of them and deepen our thought process a little bit more. Here you have a case, pseudophakic bullous keratopathy. I know I have to do this thing. I know that iris is probably defected, but more important, the lens is unstable. As soon as I go in, there's a thick membrane, and I'm not going to show you most of this procedure, just showing you to build the case up as to how complex it can get. What I've done here is I've placed a trocar, I've made my flaps, I've removed the host Descemet's membrane, done my vitrectomy. There is a subluxated IOL, and predominantly in these cases, you will find the IOL is the reason for most of this. I did manage to remove the haptics, externalize the haptics. Now, what is the purpose of the pupilloplasty? If you don't do the pupilloplasty, this air, when you install, when you push air inside, it's all going to go in the back. So I have to do this pupilloplasty. You can do any technique of the 4, whichever you choose, but a pupilloplasty is a must. And I found SFT, or single pass 4-through, the easiest to do with least manipulation, with fastest recovery. That's the predominant reason why you do it. It's not like one procedure is better than the rest. If you're used to something, please go ahead and do that. But if you're not, then, and you're trying to get into something, this is a very, very good technique. Now, what this basically does is helps me create a tamponade effect where the air can actually push up. And now see, the air does not go down. A hint of that is when you're trying to remove the host Descemet a little bit more, or removing the tags in this case. I did go ahead and implant that. Now, basically what I'm trying to show over here is that air now stays constantly, because I have ensured that the pupil does not allow the air to go down. This is the pre-op, this is the post-op 15 days and 45-day post-op of the same patient after a glued SFT and PDEC case. So that was my first topic. I think I have another one. So I think am I sharing screen? Not yet. Is my screen, is it being shared? Can you guys hear me?
Yes.
Okay.
We can hear you, and we see the title slide.
Okay. Do you see it play?
Yes.
Okay. Okay, so in this case, let me just give a little bit of backup on this case. This was a patient which normal cataract surgery was being conducted, and in one of the push of the phaco probe inside the eye, that incision, the iris did get caught, and then there was an iridodialysis. So that's basically what the case is all about. Now, what I wanted to show you is, I'm not going to show you the cataract portion of it much. What I'm doing here is a peritomy at the site of the iridodialysis. I'm creating a small scleral ridge with a little bit of tunneling. I'm doing my cataract procedure. While I'm doing this cataract procedure, I need to make sure that this iris does not come in my way. So I'm putting an iris hook during that time. Now, I also wanted to explain this procedure was told to me by Dr. Ravi Kumar. I think he's from Bangalore. So just mentioning his name as well is very important over here. Also, so once my cataract procedure is done and I've placed my IOL inside the bag, now it's time to address that iridodialysis. So I push in viscoelastic inside the eye to fill the bag, make my paracentesis all the way in the opposite side, which, by the way, I'll tell you at later point is not really fully necessary. Now, what's the apparatus over here? Now, the apparatus here is a 26 gauge needle and a ninoprolene suture. I am feeding the ninoprolene into the 26 gauge needle. Why am I doing this? Now, once I feed it in, I pull it off all the way from the other side. I feed the whole thread, the whole needle in all the way till the end. Now let's understand what's happening here. What am I trying to do? I'm trying to use this as a sewing machine, basically going in, going through the ridge and coming out. I mean, the animation is pretty self-explanatory. I'm going to tie 1 to 2, 3 to 4. So that's as simple as it is. Let me try and show it in real time. So what I'm doing is taking the iris tissue at the root of the iris, bringing it out of the scleral ridge, which I've created. So that's a free end now. Now I have a loop. This is my first loop. Again, take iris tissue, come out. As many times, I mean, you can keep going as many times as you want. But the idea here is, this is what I've created. A free end, 2 loops. Once you have free end and 2 loops, you go back inside, chop off the rest of the needle. Now you don't need anything else. You just need to cut the loops in the middle. Cut the loops in the middle. Throw it 3 times, 2 times, 1 time as per your knot desire. How many ever knots you want to tie. Again, tie 1 to 2, 3 to 4. If you do 2 to 3, that's exactly the same thing. So that really doesn't serve the purpose. You have to go crisscross. You have to match 1 to 2 and 3 to 4. Once that is done, pretty much that's the end of the case. I put some glue under the conjunctiva and close this case up. I just want to add a few points at the end of these procedures. I really always like to do a little bit of pupilloplasty nowadays. And I'll tell you a reason why. I think is what Priya showed was very important, of pinholing that pupil size or bringing it down. I think Brandon also talks about it. This is another case which is a little more complex. Let's take the complexity a little bit more. In interest of time, I'm just going to go ahead and tell you what happened in this case. Was I had to go in and it was not a pleasant sight in terms of getting the cataract or nucleus out, but I did manage to get that nucleus out. But there was a huge amount of subluxation as well. So I had to use a vitrectomy. I went into this thing, did a PVD induction as well. But idea here is you have to again create that base. So I really had to do a IOL implantation using the glue dial technique in this case. Once my glue dial is tucked into place, again, I create my apparatus, which is, so always go a little bit diagonal. It helps bringing that needle out. So that's one, that's the free end. Now is the loop, and this is the second loop. Once you have the 2 loops out, come out, cut in the center of those loops, tie 1 to 2, 3 to 4, and let all the others be snapped up. We don't really need anything else. Again, adding to see that edge of the optic as well as the little bit of the haptic that you can see. And I'll show you that in the last picture after gluing this case out. So you just close it with glue. And if you see that at the end here, if you see this picture at the end, I would always do a little bit of pupilloplasty just to close that wound at the end. Thank you so much.
Fantastic. I've learned so much this morning. Thank you for all the innovation. You guys are absolutely masters. So thank you for sharing those amazing videos and all your pearls. And now the part that I think is incredibly helpful is to answer the questions from our attendees all over the world. So I'm first going to start with Nicole Fram.
Yes.
And I'd like you, Nick, to take the mic and to answer the questions that you feel are most pertinent.
Well, I think there were a lot of thanks to everyone. These talks have been amazing. I'm taking new techniques to the OR once we can get in there again. So, you know, a lot of questions were about the artificial iris. And Brandon showed these amazing videos, and it's really one of the most satisfying things that we do. The key for in the bag is that you want it to be fiber-free. The reason why you want it to be fiber-free is it's more flexible. Your capsular rhexis size should be about 5.5 to 6 millimeters. That's to avoid anterior capsule phimosis, but also to be able to get the actual artificial iris into the bag. You must stain the bag so you can see when you put the artificial iris in. You must put a CTR, because if you get fibrosis and buckling, it'll happen more common if you don't have a CTR in the bag. But to avoid that phimosis, and that came up a lot, you want to make a big rhexis, clean your lens epithelial cells, and then you put it through a 3 millimeter incision through a larger capsular rhexis size. So that's the key. Those are the key points within the bag artificial iris. Now, when you're putting it in the sulcus, what we've learned is that you don't want to trephinate it. It's about 12.8 millimeters. And so you're putting in the sulcus, don't trephinate. Let's say you're putting it under something that for transillumination defects, make sure you put iris hooks in the natural iris, then put it into the eye. Because if you're trying to kind of get this big iris underneath the natural iris, you're going to bang up on that cornea. And that's something we had to learn the hard way. That's a really big pearl. So when you're doing passive fixation in the sulcus, and there's a lot of remnant iris tissue, make sure you put iris hooks in on the remnant iris tissue, get the iris into the eye, tuck it under, then take your hooks out, and then use your myotics to bring the pupil down. So those are the pearls there. Then always be ready for scleral fixation. So you have to have your anterior vitrectomy techniques, your suture IOL, the IOL that's in the bag has to be fixated, whether it's in the bag or you need to do any sort of intrascleral fixation or suture lasso fixation to make sure that thing is fixated. Then most commonly, we're fixating the iris through the same sclerotomies sometimes, or different sclerotomies with Gore-Tex suture, which is off-label use of the Gore-Tex suture, but it works out very well. You can use Prolene as well.
Wonderful, thank you. Dr. Narang, would you like to address some questions?
Yeah, sure.
And while Dr. Narang is...
A lot of questions.
Go ahead.
I was just going to say, Dr. Narang, there were a lot of questions about, like, can you see the retina through this small
Yes.
pinhole pupilloplasty, and what do we do if they need retina surgery?
Yeah, absolutely.
Right.
I saw those questions. Yes. I think that's a very valid point, because when it comes to a small pupil, and that to an extra small pupil of about 1.5, everybody would have this question. So that's what I was just trying to emphasize on that yes, the pupil does dilate to a certain extent, and it does allow posterior segment examination of the cases. And that they have done a study, I think Dr. Agarwal group themselves have done the study, wherein they have documented enough pupillary dilation that allows posterior segment visualization in all these cases. And I think it has been published also, and doing perimetry especially. I hope everybody can hear me.
Yes.
Yes.
Yeah. So, and perimetry has also been done in these cases, and they have, I think they have entirely documented this thing. So, but on another perspective, that I would say that yes, that's a very valid question. Then how do you see the entire posterior segment with that? So I would just say, trying to balance this, I would just try to say that you would just try to dilate these eyes and just try to see the posterior segment from the aspect of a posterior segment surgeon. If there is anything that you would feel that you need to have a look at the extreme periphery, or if you're suspecting something, probably maybe you might do in a UVM or something. And in case if you really are very concerned and you want to have a much more size of the pupil to see, then maybe you can try doing a YAG laser, and you can try removing the suture. And going one step further, if it is not there, and if some intraoperative maneuver is to be done, then I would definitely say that yes, the suture needs to be removed, and it's not difficult to remove it. It comes off.
Thank you. Thank you. Ashvin, did you have some comments?
I just wanted to tell people just stay back because there's some extremely exciting questions here, and I think they really can be answered very well. And Brandon and others as well are going to answer them. So just stay back, even if 15 minutes is not going to take too much, but you'll actually learn a lot from the stalwarts that I have on the panel here. So yeah, Brandon,
Okay, so
take some questions.
Brandon.
Yeah, so I tried to answer some of the questions while we were, during some of the presentations, but there were lots of issues with, where do you get the Ayres, where, how much does it cost? And right now, at least in the States, the Ayres is quite expensive at about $7,500. And it's distributed in the US by Veo Ophthalmics. Worldwide, though, I'm not quite sure. The web address for the company that makes the prosthesis is humanoptics.com. And I saw there's questions coming in both via text and in the Q&A.
Right.
So I'm trying to track both of them. But one of them, it looks like somebody has a horrendoma, right, where there's a large iridodialysis where the iris is all clumped up and a partially subluxed lens. And how would you manage, a patient like that? And I think, in a case where the chance for good iris repair is low, and you have a very challenging cataract, the way I would do this, and Nicole, see what you think, or other panelists, is at this point, I would just say that's a cataract surgery with a probable vitrectomy, maybe taking out the entire lens, maybe not, depending on how well you can support the lens. And at this point, I would say I would try and get that patient into the, into an artificial iris versus trying to repair a crinkled up, smushed up iris. But if this was 2 or 3 years ago, I would have said, I'll do the best I can to repair that iris. But those are the kind of cases where I think you've got to be ready to do a real vitrectomy, a pars plana vitrectomy, remove the lens, lensectomy, remove the capsule, and then independently suture an IOL and possibly an iris prosthesis. What do you think, Nicole?
Yeah, I agree. I mean, some patients, the artificial iris is cost prohibitive. So I'll tell them I'm going to try to do the best I can. And one of the things that I think, Alan Crandall and Ike Ahmed and many others have taught me over the years is that you can actually use your microforceps and pull on the tissue to see if it's fibrotic. Will it move? Is it too atrophic to suture? And those kind of tests intraoperatively will let you know whether it's even worth it to undergo, a cerclage or iridodialysis repair, or to come back another day, order the artificial iris and put it in secondarily.
So there's a question also came through of how we manage patients with the off-tech artificial iris or iris prosthesis. And I've used both in the past, the off-tech and the Morcher iris prosthesis. But comparing the different prostheses, I think that the Human Optics prosthesis looks much more natural and it has a very nice color match system. So those are the prostheses that we used to use. And in the US, we had to do a expanded access, or what was called a compassionate use IRB, to get those imported in the US because they're not FDA approved. But now we have approval. And then the nice thing now is also, at least Medicare does have codes for the iris prosthesis and will likely have surgical codes as well pretty soon. So the high cost issue of the iris prosthesis is starting to come under better control. And I think in the next year or so, for the right patient, it'll be a covered procedure.
Right. So the other thing that we should point out is that Mike Snyder really championed this entire study, and through the work of Sam Maskett, Mike Snyder, and Kevin Miller, they've really pushed the field forward in this area. It's really important to understand that these are not for cosmetic only use, and these are not to be put in the anterior chamber on top of the iris to change eye color. And I don't know if we emphasize that enough. You cannot just take this and put it on top of the iris. There's, different iris prosthesis that we've all seen where people have put in the anterior chamber and destroyed eyeballs, destroyed the cornea, destroyed the angle and the iris. So it's really important to understand this is a silicone elastomer that should be placed in the sulcus or in the bag. That's it.
Right. This is a reconstructive procedure. It has a cosmetic outcome to it, but it's not for a cosmetic purpose. And that was very clear in the study. It was not for cosmesis.
Thank you for those comments. Are there any cosmetic iris implants that you guys feel are safe for placement in the eye at this point?
That's easy. No.
Correct, right. I think that's really important. There's nothing out there that's safe. So those are all, they lead to some significant and serious complications. Thank you. Ashvin, would you like to address some questions?
There are actually a lot of questions, and I do think there's a lot of excitement, and I think it's very important that we keep this follow thread on. I don't think in 5 minutes I'll be able to answer every single question, but definitely follow me on Instagram or on Facebook. And I'm very, very happy to actually answer any of your questions. I think the most important point which I want to take away from this whole thing is that even in the midst of all this adversary that we are seeing around the world right now, I think we've all stepped up in terms of, especially my panel over here, and all the participants who came in today. We've all stepped up to learn something new. Most important is, stay safe and this thing. I will definitely keep reaching out to you guys for different reasons. Sorry, panel. I need your guys' help for a lot more than just this one. But yeah, I think we might want to close in about 4 or 5 minutes. But
So
yeah.
Ashvin, Dr. Kumar's contribution with the sewing machine technique is unbelievable.
Yeah.
And I've read the articles and I've tried to do it, but the way you demonstrated it was so great. Can you go through again the ease at which you put the needle, like the 27 gauge? Are you doing 9-0 or are you doing 10-0 polypropylene?
Okay. I did a 10-0 Prolene. Yeah, that's a good point actually. I didn't mention that. I think that animation is what changes a lot, especially in the mindset, at least for me. Only when I was able to get that animation was I able to teach people properly or better. So once you remove the iris hook after the surgery, after the cataract is removed, you go and make a paracentesis on the opposite side. Make sure that your iris is ready. Now, 26 gauge needle and a 9-0 Prolene suture. Thread. You can use a 9-0 or a 10-0. So one question that was asked to me was, can you guys see it?
No.
Okay, just a second. I'm just going to.
And it's a straight needle, correct? That you put into.
It is an absolutely straight needle. All right, I'm going to share my screen. There we go. Yes. Okay. Can you guys see this now?
Yes.
Okay. So the 26 gauge needle and the 9-0 Prolene suture, this is the apparatus being made right now. So one question is, where do you make the paracentesis? So this distance is actually a bit too long. If you see, I'm just going to try and draw. Yeah, I'm going to draw.
Oh, you want to be like Brandon. Be
I don't
careful.
know if I can, but I'm not as good as him. Yeah.
That was good, Brandon.
Yeah, I'm not able to draw. Okay, mouse. Okay, this distance is actually too long. Can you see my mouse?
No.
No. Okay.
Some people aren't seeing your screen either. Just describe it.
Okay, I'll explain it. So I'm just going to play it for some time. Can you guys see the play?
No.
It's not playing?
No.
Okay, wait.
All right.
It's playing for me, but I'm just going to do it again. Hold on. Can you see the screen now?
Yes.
Play?
Yes.
It started, yes.
So here, the idea here, which I've shown in the end, if you look at this closely, this distance from the end of this paracentesis to the iris repair is a bit too long. So what I've started to do nowadays is use a side entry and bend the needle after the apparatus is ready. You can't bend the needle before, because then you can't pass the 9-0 Prolene in. So you pass the 9-0 Prolene in, bend the needle, and then you're ready with your apparatus. So that's what I started to do now. Because that was a question that the mouth of the needle, that is the mouth of the 26 gauge, is too short So it gets stuck. Yeah, it doesn't go out of the scleral ridge which you have created. So now, anyways, the idea here is you go in through the iris root, come out of the scleral ridge and come out, hold the loop, come out, hold the loop, because they always have a tendency to trace back inside. There's always this tendency that it follows the needle back inside. So just hold the loop and make sure that it does not go out. Now, once you're done with this, there's another question that was asked to me: why don't you just take that and thread it through the loops and just tie it? That's definitely an approach. I just found this much easier and better to explain one. And also, I do this. I personally do this technique, and it's worked for me. It holds the iris in place. I'm able to do a pupilloplasty also after this. So even in case I do get some defect, it always happens invariably in this procedure, or any iris iridodialysis, you will have a peaking of a pupil at that side. And so you will have to accompany this with pupil repair as well. So that's my loop. And that's the free end. I'm sorry. That is the free end. This is the loop, first loop. Again, I'm holding it even while I'm going back. Holding the second loop even while I'm going back. Come out, cut. Now, this is what you have. And cut in the middle. It's rather simplicity is why I've chosen this technique rather than going through the loops. I mean, if that answers your question, to whomever asked me that question. But yeah, this is basically why I do this technique.
Great.
Okay, I'm going to stop that.
Fantastic. Any final comments from the panelists? Any parting words of wisdom?
Follow all of us on our social media pages, and we will really be glad to accept this thing, and as well as answer all your questions. I think that is my last comment, because there are too many questions right now coming in, and I really want to answer all of them, but I don't want to hold. I've already held Nicole, Priya, Brandon, and Deep for too long. So thank you so much. Yeah.
Okay, well, thank you, everyone.
Thank you.
Be safe, be strong, stay positive. This too shall pass. And we look forward to seeing each other in person sometime very soon. Be well.
Thank you.
Thank you.
Bye.
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 Thank you, everyone, for attending.
Bye.
Bye.
Thank you.